Thank you, Dr. Ashay, Dr. Kumar, Dr. Vanita, Dr. Amin, Dr. Vijay, for giving me this chance. So I will be discussing amivantinib in EGFR exon 20 insertion mutated non-small cell lung cancer progressing on platinum-based chemo. And these are the initial results from CHRYSALIS phase 1 study. So I am grateful to TMH and I am grateful to the place that I am presently working, Dharamshila Narayana Hospital. I am grateful to my mentors and teachers. So with this, I will begin my presentation. Some of the slides have been already been discussed. So exon 20 insertion, they account for approximately 12% of EGFR mutations. And this pie chart, it's showing the distribution of the EGFR mutations.
Rajit, the slides are not visible. Have you shared the slides screen?
Yeah, I have shared my slides. So,
No, share the
so
screen. You wanted to place from our side?
yeah, maybe you can play it from your side.
Sure. Yeah, you can just say next. Yeah, whatever.
Next. So as I discussed that exon 20 insertion accounts for 12% of EGFR mutations. This has already been discussed. Next slide. So there are it is a very heterogeneous group with more than 100 variants. So various studies have been done, like this study which was done by comprehensive genomic profiling by Foundation One in around 14,000 non-small cell lung cancer. There were more than 260 EGFR exon 20 insertions. So it is basically a very heterogeneous group of mutations. Next slide. So important point that I would like to highlight in this slide that PCR can miss up to 49% of EGFR exon 20 insertion. So the ideal test to find out EGFR exon 20 insertion is an NGS. So these are two studies which have compared and tested EGFR exon 20 insertions by PCR and NGS. So they found that the PCR can miss up to 49% of the EGFR exon 20 insertion. Next slide. So real world outcomes in patients with advanced non-small cell lung cancer with EGFR exon 20 insertion remains poor. So even with platinum based treatment or TKI alone, the overall survival remains poor. Overall survival with platinum based is around 17.4, with TKI it's around 9.4. And the 5-year OS is 8% as compared to other TKI, which is around 19 to 20%. Next slide. So coming to the molecule that we'll discuss, amivantinib is a bispecific antibody which acts on EGFR and MET. It is a fully humanized bispecific Ig1 antibody targeting both EGFR and MET mutation/amplification. So there are three mechanisms of actions. It acts via receptor degradation, it acts via immune cell directing activity, and it acts via inhibition of ligand binding. So in preclinical and prior studies, it has demonstrated activity as monotherapy in activating and resistance EGFR mutations. Next slide. So coming to the study design of this one cohort of the CHRYSALIS trial. CHRYSALIS is basically a multi-center ongoing randomized open label multi-cohort study. So in this study, post-platinum advanced non-small cell lung cancer patients with EGFR exon 20 insertion mutations. It was a two-part study. The dose escalation and expansion study. In the primary objective of the dose escalation was to determine the maximum tolerated dose, and the recommended phase 2 dose and that of the dose expansion was to evaluate the safety, tolerability, and the anti-tumor activity. So basically around 114 patients, they were evaluated and were eligible for safety population, and around 81% of the around 81 patients were eligible for the efficacy calculation or the efficacy population. The primary endpoint was overall response rate, and the secondary endpoint was PFS and OS. The dose was calculated from the initial dose escalation study, and it was in the second part of the dose expansion study. It was 1050 milligram for less than 80 kg and 1400 milligram for more than 80 kg, day 1, day 8, and then every two weekly. Next slide. So the baseline characteristics in the efficacy population, around 22% patients had history of brain mets, and most of them had received prior treatment. Median prior lines of therapy were 2, and all the patients received prior platinum therapy. Around 46% patients received prior immunotherapy, and few patients had already received prior TKI. The overall response rate was around 29 to 51%, and the was around 40%. The median duration of response was around 11.1 month. 4% patient had a complete response, and partial response was present in around 36% of the patient. So the combined response was around 74%, that included both CRPR and stable disease. Next slide. And this slide is showing the waterfall plot is showing the response rate and the different type of exon 20 insertion that were found in this study. So based on the NGS, they were the exon 20 insertion, they were found either in the helical region, in the near loop, far loop, and they were not detected by ctDNA. The best response that were present in those patients who had NGS insertion in the helical region. You can see that the overall response rate was 100% in those patients who had an exon 20 insertion at the helical region. Next slide. So this is a complicated graph, but it is what it is trying to show the duration of response and those patients who had stable disease and partial response. So 47% of the patients, they remained on treatment at the data cutoff, and 63% of patients had responses for more than 6 months. The median PFS was 8.3 months and median OS was 22.8 months. Next slide. And coming to the safety profile, most of the side effects were tolerable. Rash was one of the prominent side effects. Grade 3 rash was present in 4% of the patients. Paronychia grade 3 was present in one patient. And MET-related side effects were hypoalbuminemia and peripheral edema. And grade 3 hypoalbuminemia was present in 3% of the patients. The infusion reaction primarily occurred during the first infusion in 94% of the cases, and it did not impact the ability to receive subsequent treatments. Next slide. So there are plenty of exon 20 insertion treatment that are presently available. So we already discussed mobocertinib. There is also poziotinib, which is yet the FD approval is pending, and we discussed amivantinib. The overall response rate with the poziotinib is around 55%, with PFS of 5.5%, 5.5 months. With mobocertinib, the overall response is 25 to 28%, with the median PFS of 7.3, and with amivantinib, it is 40% and median PFS of 8.3 months. Next slide. So out of these, two drugs have been approved by FDA, that is amivantinib and mobocertinib, and there are plenty of drugs that are in pipeline. Next slide. So, so, so CHRYSALIS is a multi-cohort study. It is also evaluating in those patients who already received osimertinib, and it is also combining one more drug in patients who are osimertinib resistant. And it is also there is a study called Papillon study, which is combining amivantinib plus chemo versus chemotherapy in advanced or metastatic non-small cell lung cancer with EGFR exon 20 insertion. So basically, this is a new ray of hope for a very poor profile of patient, that is exon 20, where we before these drugs we did not have any standard of treatment available. So the future look good for exon 20 insertion. So with this, I would like to conclude my presentation and would like to thank the organizers.
Thank you, Raajit, for wonderfully summarizing. Now, I would like to invite Dr. Aditya Murli, consultant medical oncologist, Aster Hospital, Bangalore. He will be speaking about positioning for